Thank you, Dr. Yang. I would like to thank the GTSC for the opportunity to present our work. We have nothing to disclose. Although lobectomy is the mainstay of therapy for resectable lung cancer, its approach was initially controversial between VATS or open thoracotomy. Several studies have shown that VATS is a safe and effective approach and offers several advantages at the patient level in terms of postoperative pain and shorter lengths of stay. Similarly, several studies have shown that the VATS approach is oncologically equivalent, if not superior, to the open approach. However, despite these proven advantages, the overall VATS utilization rate in the US remains low, and the hospital-level variation in VATS lobectomy is unknown. In this context, we ask the following three questions. What is the magnitude of hospital-level variation in VATS lobectomy across the US? Is this variation driven by case mix differences and or the availability of equipment at the hospital level? And does this variation affect postoperative outcomes? To answer these questions, we use data from the National Cancer Database, or the NCDB, looking at lobectomies performed in the US between 2010 and 2012. We defined the VATS approach as any video-assisted approach based on intent, including robotic cases and those converted to open. We excluded hospitals that had less than 5 lobectomies per year to limit chance variation, and then used hierarchical logistic regression to estimate risk and reliability adjusted VATS lobectomy rates, and then group these hospitals into quintiles. In order not to penalize hospitals that don't have thoracoscopic towers, staplers, and so on, we obtained data on VATS wedge resections as a surrogate marker for the availability of VATS equipment. We defined the hospital as having VATS equipment if they had performed any VATS wedge resection during the study period. So in total, we had 56,000 patients that underwent a lobectomy at 905 hospitals. A VATS approach was utilized in 30% of these cases, or 17,000 patients. The x-axis on this graph shows the quintiles, with the one on the far left, or the highest one, the lightest shade one, the hospitals that have the highest VATS utilization rates. As you can see here, there's a huge variation between hospitals that ranges from 1% to 76%. This is after case mix adjustment and accounting for equipment. If we look at the patient characteristics between these quintiles, and just for simplicity purposes, I only show the 3 quintiles with the second and fourth omitted from this table. You can see that the patients were similar in their age, gender, race, Charlson comorbidity score, and insurance status. Even though they are statistically significant, this is common in administrative studies, and they have clinically no meaning. Similarly, their tumor profiles were also equivalent between quintiles. So their histology, the clinical T stage, and the clinical N stage was similar. Looking at the VATS availability at hospitals, we see that the majority of hospitals had evidence by our surrogate marker for the availability of VATS equipment. So this means that this large variation is not driven by lack of equipment at the hospital level. This heat map here is a regional variation model that takes the average patient, so this is the exact same patient, and adjusts all the factors that we discussed earlier, and gives you a probability of their risk-adjusted chance of getting a VATS lobectomy. So a patient, for instance, in New Jersey or New York has the highest probability of getting a VATS lobectomy compared to a patient who's in Oklahoma, for instance, who have the lowest rate of a VATS lobectomy. So it's the exact same patient, and geography is destiny. In terms of postoperative outcomes at the hospital level, so again, the x-axis here has the 3 specific NCDB outcomes: readmission, 30-day mortality, and 90-day mortality. And you can see there's really no difference between the hospitals in terms of these 3 outcomes. The only difference, which is not shown here, was length of stay, with hospitals in the highest VATS quintile having, on average, a day shorter length of stay. This study has several limitations. First of all, NCDB does not have surgeon-specific data, so we don't know who's who and who's performing what at these hospitals. However, the hospital is the appropriate unit of analysis in variation studies, and hospitals have the leverage to affect or influence surgeon practices. Also, the NCDB only has hospitals that are accredited by the Commission on Cancer, the COC, so the results may not be generalizable. However, the NCDB captures over 70% of all cancer cases in the US and is one of the authoritative sources for regional variation studies and cancer. So in conclusion, about 1 in 3 cancer lobectomies in the US are performed via VATS approach. However, there is a wide variation between hospitals that ranges from 1% to 76%. This variation is not due to case mix or lack of equipment. Rather, it is due to regional variation and the availability of expertise and/or preferences at the hospital level. Postoperative outcomes are equivalent at both ends of the VATS adoption spectrum, which means that there are high-quality hospitals at both ends. This suggests that there is a need for novel training opportunities for surgeons to reduce this variation. Thank you, and I'd be happy to take any questions.